Welcome to Mayo Clinic Sleep Medicine Podcasts, a series for physicians, advanced practice providers, nurses, and other health practitioners treating sleep disorders or interested in learning about state-of-the-art advances in sleep medicine and sleep health. I'm your host, Dr. Michael Silber.
And I'm your co-host, Dr. Maitri Juna. We are both consultants at the Center for Sleep Medicine at the Mayo Clinic in Rochester, Minnesota.
Headaches are among the most common chronic disorders. The relationship of headaches to sleep is complex and important in understanding head pain and its management. To discuss this important topic, my guest today is Dr. Anne Murray, a board-certified pediatric neurologist and sleep specialist with special expertise in headache disorders, coming from Mayo Clinic in Rochester, Minnesota. Anne, thank you for coming on today.
Thank you
Let's
for having me.
start. Let's start with the commonest headache disorder, migraine. It's commonly taught that many migraine headaches start during sleep. Is this actually correct? If so, do we understand why the sleep state may predispose to migraine headaches?
So there's definitely a connection between sleep and migraines, but the relationship seems a little bit more nuanced than we previously thought. I don't think we can accurately say 50% start during sleep. Some older studies back in 1998, Fox and Davis looked at circadian variation and identified that nearly 50% of attacks happened between 4 a.m. and 9 a.m. with a peak around 6 a.m. But as far as I'm aware, they didn't specify whether they were awakening headaches or what their sleep state was at that time. Some subsequent studies have looked at patterns of headaches and timing of them, but not reliably reporting the awakening, and sometimes lumping together whether it was disrupting sleep, waking from sleep, preventing sleep, or thereupon awakening. And so it's a little difficult for us to say that. What we do know, or we do see consistently, is that the majority of patients do say that they have occasional headaches that awaken them from their sleep. And we know that sleep disruption is a trigger in probably at least 50% of migraine patients, but not specifically one type of sleep disruption. So it can be either too much, too little, or irregular sleep in those cases.
So it might be sort of a circadian issue rather than sleep-related issue that they sometimes happen at night.
It could be. It could be. There's certainly a lot of shared neuroanatomical pathways between sleep and migraine as far as pathophysiology, particularly the hypothalamus, the involvement of that in both sleep disorders, circadian rhythm, and migraine disorders as well.
So, as you mentioned, sleep disruption may precipitate a migraine attack, but sort of paradoxically, many patients also report that going to sleep terminates an attack of migraine. Is this belief borne out by studies? And if so, what could be the mechanisms of this? And sort of a corollary to that question is, as you counsel your patients, do you pay special attention to sleep hygiene when counseling children and or adults with chronic migraine?
Yeah, good question. So we do see in the literature that patients report sleep as an acute treatment, um, and terminating an attack at times, and quite frequently actually. And I see that borne out in my practice as well. The sleep disruption, as you said, is a common trigger. And I say sleep disruption differing from sleep deprivation because initially I think the teaching was more sleep deprivation, but recent studies have been shown that it's maybe a little more complicated in that it might be more irregular sleep than it is the actual hours of sleep. But it's kind of varies depending on what study you look at. But practicing or encouraging regular sleep, avoiding sleep variation in either duration or schedule is a really important part of comprehensive headache care.
Mm.
Um, in my practice, I absolutely do. And one might say I'm a little biased because I'm sleep medicine, but in studies looking at physicians counseling patients on headache, I'm not alone. The In my practices in headache is primarily adolescents with headaches, and we know that there's a lot of social factors that contribute to significant disruption, whether it's school, extracurriculars, homework, social media, screens, things like that, that really put them at a risk for sleep disruption. And that I see that we see it commonly in adolescence that there is more sleep disorders, and not one specific one, but commonly insomnia that often goes undiagnosed. So there was a questionnaire-based study that looked at um, adolescents specifically with migraine, and 70% of them had disordered sleep based on questionnaires, but only 5% of them were diagnosed. So it's probably sleep disorders are underdiagnosed in that population, but we also see that it can be impactful to treat them. So, cognitive behavioral therapy for insomnia, for example, does result in improved headache control as well.
Oh, good. Well, let's move on and next consider a much rarer condition, but one even more intimately related to sleep, and that's the um, unusual headache condition called cluster headaches. For those of our listeners who are not neurologists, tell us just a little bit about cluster headaches and the frequency with which they start during sleep. Why are they thought to start often during a sleeping period?
Yeah, that's a tricky question. So to start off, I'll just explain kind of cluster headaches. They're a rare type of headache. They fall into a category of trigeminal autonomic cephalalgias, or TAC for short. They're the most common of the TAC headaches, but still a rare type of headache. So prevalence is estimated to be about 0.1%. The cluster headaches are characterized by extremely severe pain around the orbit, around the eye, the temporal region, lasting a relatively short duration, so can vary from 15 minutes to 3 hours. And what really differentiates them often from migraines is that they're associated with agitation and restlessness. So patients report pacing, rocking, rolling on the floor, can't sit still. They have also characteristically associated on the same side autonomic features, rhinorrhea, nasal congestion, sweating of the face, eyelid swelling, ptosis, lacrimation or tearing, conjunctival injection. And they can happen once every other day, up to 8 times a day by the formal definition. They're called cluster because of how they cluster in periods typically lasting 6 to 12 weeks, although they can be as short as 7 days. And they do also have this circannual rhythmicity. So they, at least in the northern hemispheres, tend to be more common in the springtime or the fall time, and often have that predictability within the individual patient. The patients also report the circadian periodicity, which is interesting to particularly to the sleep medicine side of things. The attack often happens in a predictable clockwork pattern as far as time of day, and that's frequently reported by patients, with nocturnal onset being more common. Frequently reporting patients are reporting awakening from their sleep, and when studied, the most common hours fall between 9 p.m. and 3 a.m. Those with cluster have lower quality of sleep, both during bouts like the clusters of their headache attacks, but also during their remission periods. Um, the Why do they come from sleep, or why do they arise from sleep more frequently? We don't really know why. We know that there's involvement of the hypothalamus, the trigeminovascular system, the autonomic system. Um, but it's still a work in progress as far as what we know about that. The hypothalamus, as I alluded to earlier, talking about migraines, is activated, and it's been demonstrated to be activated at the start of cluster attacks and felt to be involved in the initiation of the attacks. And the circadian pattern to it would support that as well. Um, the we know that that's an important regulator of circadian rhythm and sleep-wake signaling, um, but exactly why or how is still kind of a mystery to us. There are treatments such as melatonin, lithium, verapamil, deep brain stimulation that also support the idea of hypothalamic activation as part of the pathophysiology.
Hmm, very, very interesting. Now, one of the intriguing treatments for acute cluster headaches is something quite unpredictable, and that's high flow oxygen. Now, obviously, sleep specialists hear oxygen, and we think, of course, of hypoxemia. Is that the mechanism? How does high flow oxygen work to stop these terrible attacks of pain?
Yeah, that's right. So oxygen is one of the first line treatments for
Hmm.
acute treatment of attacks, specifically high flow oxygen through a non-rebreather mask. And there was a nice kind of landmark trial that looked at specifically high flow of oxygen compared to high flow of air. So both the flow, the oxygen, the
Mhm.
mask appears to be important. And the typical, depending who you talk to or what you look at, the rate might be different, but typically 100% oxygen at 12 to 15 liters per minute for 15 to 20 minutes with the correct mass type. And a different mass type, incorrect mass type, or lower flow may affect the efficacy of it. Similarly, we don't know why oxygen works for cluster headaches. It has been a standard treatment. The first reported usage was in the 1950s, and we believe it to be a different mechanism than just correcting hypoxemia and respiratory conditions like we do in sleep medicine. The suggested mechanisms include inhibition of some cranial autonomic pathways, modulation of neurotransmitters, and reduction of cerebral blood flow or vasoconstriction. Though interestingly, the other trigeminal autonomic cephalalgias don't respond to oxygen, and that's kind of a classic differentiator between cluster and some of its cousins, you might say. There was a really cool study done in 2009 by Ackerman and Goadsby and colleagues that looked at a rat model and showed that oxygen acted more directly on the parasympathetic outflow rather than on the trigeminal afferents, which would fit with why the oxygen is typically not helpful for migraine, for example. And so that was kind of a cool thing, but we're still a bit of a mystery to us.
Very interesting. Well, let's move from a rare condition to an extremely common one. When we're taking a history, trying to determine if a patient has obstructive sleep apnea, one of the questions we routinely ask is whether a headache is present on waking in the morning. And I noted there's been a 2024 meta-analysis of 6 studies suggesting a relative risk of morning headaches in patients with sleep apnea compared to those without was only 1.43. And in fact, the confidence limits went across zero, so it wasn't statistically significant at all. Does sleep apnea cause morning headaches, or should we just drop this question altogether? And if it does cause headaches, is the mechanism, as we rather simplistically tell patients, well, it's due to your low oxygen or maybe your high carbon dioxide? What causes headaches from sleep apnea, if in fact it does cause it?
Yeah, so it's a tricky thing for a few different reasons to study. But we can, I think, comfortably say that frequent or chronic morning headaches are more common in sleep apnea versus those without. Um, and and as we look into it from a research standpoint, there's a lot of variability in how people define the entity that they are studying when it comes to morning headaches. So we have an international classification of headache disorders, the ICHD-3, that has a pretty strict definition of a sleep apnea headache that really include diagnostic criteria of it has to have a temporal relationship to the onset of the sleep apnea and has to correlate with improvement or worsening. And it has to lack other features such as migraine features. And then the real kicker, and this is in all of our diagnostic criteria in that international classification of headache disorders, is that it can't be accounted for by another diagnosis. When you're dealing with headache disorders where you don't have biomarkers, that's a tricky thing. So when looking at these meta-analyses and systematic reviews, such as the one you mentioned of 2024, it's challenging to compare studies when they use different criteria for that. A lot of the studies lack the ICHD-3 criteria. They either weren't able to collect that or didn't use those definitions. The studies also generally look at an older population, so they're more skewed towards older people who may report less headache in general. And there's a lot of variability in the prevalence of morning headaches when you look from study to study as well. There's also the fact that we just talked about earlier that migraine headaches can have onset in those early morning hours. So differentiating between migraine headaches and headaches caused or related to the sleep apnea is a challenging one. My bias as a headache provider is I do ask about headache because I manage that and I care about that. Whether it's beneficial to ask from a sleep provider perspective, it doesn't hurt to ask, but I would caution drawing too many conclusions for it. There was a study that looked at PAP therapy and how it decreased morning headaches, and it was helpful in decreasing headache prevalence and severity, and it correlated with improved daytime sleepiness scores. So maybe it could be used as sort of if you can identify the patients who have morning headache, you can maybe track that, and it can be used maybe to encourage their usage of their PAP therapy, which we know is a challenging thing. But it makes it difficult to say what the mechanism is, but it doesn't seem to be solely respiratory parameters, because there's a lot of conflicting studies on those as well. So people who had worse parameters for things like lowest oxygen desaturation, degree of oxygen desaturation, overall mean oxygen saturations, sometimes they had better parameters if they had more headaches, sometimes they had worse, and sometimes there was no difference. So it's hard to know what to take from that as far as what the mechanism is. But again, my bias is that I always ask because I do headache, but it's probably not the most helpful thing for a sleep doctor to be asking necessarily, and definitely not drawing diagnostic conclusions from it.
Good. Well, the last type of headache we might briefly discuss has the rather generic name of hypnic headaches, which are defined as a type of headache waking patients from sleep but not fulfilling criteria for another headache disorder such as migraine or cluster headaches. Is this a well-defined entity? Is it common? How should it be treated?
Yeah, so it's relatively uncommon. It's not something I typically see in my practice because that typically happens in elderly or older patients. It's the estimated prevalence within headache centers. So looking at a population, not a general population, but a population of headache patients with headache, it's widely variable, but from 0.07 to 0.35% of all headache patients. So quite rare. And all the treatments are based on typically very small studies. Most classically, treatment involves caffeine or caffeine-containing analgesics. Triptans in some studies were shown to be helpful or ineffective in other studies. Preventive treatments have included lithium, caffeine given at bedtime, indomethacin. Sometimes melatonin seem to be effective, but there's not a whole lot for us to go on, partly given to how rare it is.
Right. So, yeah, a tricky area, that one altogether. Well, Anne, thank you so much for sharing your expertise. Do you have any final messages to leave with our listeners?
Yeah, so I would just emphasize that there's a bidirectional and complex relationship between sleep and headache disorders. There's many shared neuroanatomical pathways and shared treatments, and there's a lot left for us to learn. For comprehensive headache management, I absolutely recommend screening for sleep disorders and counseling on sleep hygiene. Particularly focusing on consistency and not deviating from routines. And then to leave you with one final phrase from one of my mentors in training, good sleep is good medicine.
So it definitely is. Thank you so much. Appreciate you coming on today.
Thank you.
We hope you enjoyed this podcast. If so, please tune in again through wherever you receive your podcasts as we discuss further topics in sleep medicine and sleep health. Thank you.